We do want at this time go right into introducing our next speaker, who is Dr. Saidu Yakubu. He is an associate professor and then a consultant anesthesiologist. He works for some of the, he has helped and worked with some of the teaching hospitals in Zaria, Nigeria. In fact, he is working with Ahmadu Bello University Teaching Hospital. He's got a lot of accomplishments under his name. He's some of the things that really stood out to me is how many boards he sits on. He has been he's assistant general secretary for Intensive and Critical Care Society of Nigeria. He's also part of SABM. He's a member of the International Association for the Study of Pain. Very many different accomplishments as well. Some of the achievements that stood out to me was he was awarded the Book of Blood Works during the SABM 2024 annual meeting in Phoenix, Arizona. For being #1 on the WAHOVA leaderboard. That must have been exciting.
Thank you.
Yes, and also awarded International Multidisciplinary Perioperative Pain Prevention and Management Education, which was a grant by the IASP, which is the study of pain, for educating students and staff and continuing research for the year 2020. So we can see you've been very busy, Dr. Yakubu.
Thank you.
I want to move forward and just welcome you, introduce your part, which is perioperative techniques in bloodless surgery, a refresher and update. And so we will not use any more of your time up, and go ahead and please let us all.
Thank you. Okay, is it possible to share my slide?
Nathaniel, do you have them?
Oh, okay. I can see that it's possible for me to share. Oh, okay, please, can you see my slide?
Yes, we can see them.
Okay, it's okay?
Yes.
Good. Thank you very much. Good morning, good afternoon, good evening. I'm Dr. Saidu Yakubu. I'm an anesthesiologist based at the Ahmadu Bello University, Zaria. I'm very pleased to talk about perioperative techniques in bloodless surgery, a refresher and update. The learning objectives are: 1, identify the risks associated with allogenic blood transfusion, and for the patients to be able to list the pillars of bloodless surgery and patient blood management. And number 3, for the patient to be able to describe the perioperative blood conservation techniques. The outline of the presentation, I will introduce the topic, brief history of blood transfusion, blood conservation, patient blood management, blood conservation techniques, and then I will conclude. As a way of introduction, anemia is a common finding in trauma, surgical, critically ill, and pregnant patients. Most patients with anemia receive blood transfusion for correction. However, as we all know, perioperative blood transfusion is associated with adverse events and complications. Again, the supply of blood is decreasing, coupled with increasing costs. Various blood conservation techniques can help reduce allogenic blood transfusion, and it also helps reduce risks and conserve blood supply, and also decreases the length of hospital stay and cost of hospitalization. Bloodless surgery is a comprehensive perioperative approach that improves patients' outcome through the avoidance of allogenic blood transfusion. This is an image showing us the various risks associated with blood transfusion, the risks of transmission of infections such as the HIV/AIDS, hepatitis C, hepatitis B, cytomegalovirus, bacterial infection, parasitic infection, and other risks that are non-infectious, such as acute hemolytic transfusion reaction, febrile reactions, allergic reactions, and transfusion-related acute lung injury. Transfusion reactions could be allergic, febrile, or hemolytic. The allergic ones could be mild or severe. In the mild one, there could just be facial flushing or rash in the body, while severe ones will lead to anxiety or dyspnea, fall in blood pressure. And then the febrile ones are associated with fever, headache, tachycardia. And then the hemolytic one associated with chest pain, apprehension, body pains, and hemoglobinuria. History of blood transfusion. This was during the ancient time. The use of blood for medical treatment dates back to the 17th century. William Harvey discovered the circulation of the blood in the year 1628. James Blundell successfully transfused human blood to treat postpartum hemorrhage in the year 1818. Blood typing and cross-matching between donors and patients was introduced to improve the safety of transfusion in the year 1907. The blood group O was identified as a universal donor in 1907, and the first blood bank was established at Leningrad Hospital in the year 1932. Blood bank moved towards an all-volunteer donor base in the year 1970, and the first HIV blood screening test was licensed and introduced by the blood banks in 1985. Blood conservation techniques. Blood conservation is a combination of strategies to avoid the transfusion of allogenic blood and to improve its oxygen carrying capacity. It is a team effort involving the surgeons, anesthetists, hematologists, intensivists, pharmacists, operating room nurses, ward nurses, and other physicians. There are pharmacologic and non-pharmacologic strategies. This is an image showing the pillars of bloodless surgery. There are 4 of them. One is to optimize the hematocrit. Second, to minimize blood loss. Third, to optimize tissue oxygenation. And the fourth one is to support physiologic tolerance of anemia. We'll look at each of them. Optimizing the hematocrit. There should be prompt and complete diagnosis of anemia. And then where possible, oral iron can be given to treat. Otherwise, parenteral iron can be administered. There should also be nutritional support. And erythropoiesis stimulating agents such as erythropoietin can be administered where available. Minimizing blood loss. There is need to take a good history and perform physical examination, such that there should be prompt diagnosis and appropriate treatment of any coagulation disorder. And then there should be restriction of phlebotomies, and there is need to perform non-invasive monitoring instead of taking blood all the time. And then where there is active hemorrhage, pressures will be applied to stop them or elevate the arms or the legs, and the use of hemostats. And then drugs such as tranexamic acid can also be used to stop bleeding. Intraoperatively, there should be pneumothymia. And then, of course, acute pneumovolemic hemodilution can be performed. The anesthetist can perform a regional anesthesia where possible. And then, of course, appropriate positioning to improve blood loss. And then meticulous hemostasis and the application of tourniquet where possible, and then cell salvage and reinfusion of the blood collected. And then, of course, where possible, laparoscopic surgery can be performed. Optimizing tissue oxygenation. There should be appropriate oxygen therapy and ventilation. And then where the patient has lost blood, fluid can be administered, crystalloid if the blood loss is less than 25%, and colloids if the blood loss is greater than 25%. And then, of course, appropriate resuscitation. There should be efforts to minimize oxygen consumption. Where the patient is shivering, they should be treated so that they will not consume oxygen. If there is pain, they should be treated for pain, and then If there is infection and sepsis, they should be treated with appropriate antibiotics. And then where possible, inotropic or vasoactive agent can be administered to help raise the blood pressure. And then, of course, modified hemoglobin solutions can be used. And then supporting physiologic tolerance of anemia. This involves a prompt institution of measures to ensure hemodynamic stability, supportive oxygen, and then accelerate hematopoiesis. Limits patient activity in moderate to severe anemia so that they will not have issues. And then there should be point of care testing so that minimal blood will be lost. Normal readings of hemoglobin actually helps to reassure the team that is managing the patient, and then it is important to promptly detect derangements so that the appropriate intervention can be given. It is important to know that with adequate support, patients survive extreme anemia better than receiving blood transfusion, which is associated with a lot of morbidity and mortality. Patient blood management. This is a clinical concept to prevent unnecessary transfusions for improved patient safety and outcomes. It is a multimodal, multidisciplinary approach that requires the anesthetists, medical team, the hematologic team, and the surgical team. When they all collaborate, it helps to give a good patient outcome. It involves early detection and treatment of preoperative anemia and reduction of perioperative blood loss. It also aims to improve tolerance to anemia in the postoperative setting. Patient blood management has been developed as an evolving evidence-based approach with several key goals. One, to identify, evaluate, and manage anemia, as I mentioned earlier, to reduce iatrogenic blood loss, and to optimize hemostasis, and to establish decision thresholds for transfusion. This is a photo showing the pillars of patient blood management. One, to optimize the hematocrit. Two, minimize blood loss. Three, optimize tissue oxygenation. And four, lowering the transfusion trigger. Patient blood management shifts the focus from the product to the patient. Instead of thinking of the blood, we are now thinking of the patient. How can we make sure that the patient receives the best? It views the patient blood as a resource that should be conserved and managed appropriately in order to obtain appropriate patient care. The aim is to optimize the patient red cell mass, reduce blood loss and bleeding, and to improve tolerance to anemia. There are various areas in which blood management should be put into use: preoperatively, intraoperatively, and postoperatively. So preoperatively, the management of anemia using iron, whether oral iron or intravenous iron, the administration of erythropoietin, and autologous blood donation. There should be meticulous hemostasis, short operative time, hypotensive anesthetic techniques intraoperatively, and hemodilation. And then, of course, blood salvage and the use of pharmacologic agents such as tranexamic acid intraoperatively. Postoperative measures include meticulous postoperative monitoring of the patient, early detection of blood loss, and reduction of the collection of blood for tests, and then normalization of cardiopulmonary function and minimization of oxygen consumption. So this is a table showing the various pillars and then the various times. Preoperatively, we aim for assessment of anemia 4 to 6 weeks before the surgery, so that if there is anemia, it can be treated. And then pillar 2, identify and manage bleeding risks intraoperatively, and then minimize iatrogenic blood loss. And then post-operatively, pillar 3, compare estimated blood loss with patient-specific tolerable blood loss. And then intraoperatively, schedule surgery with optimization of red cell mass, meticulous hemostasis, and surgical techniques, if possible, in a surgery where there's anticipation of high blood loss, a surgeon that is highly competent should perform the surgery, a surgeon that is very fast, and then post-operatively stimulate erythropoiesis, and then pillar 3, maximize oxygen delivery. Jehovah's Witness, blood conservation and patient blood management is clinically relevant in surgical procedures involving the Jehovah's Witness. Jehovah's Witnesses refuse the transfusion of 4 main components of blood: the red cells, white blood cells, plasma, and platelets. They also refuse the autologous blood that has been removed from the body. The World Health Organization defines anemia as a condition with decreased number of red blood cells and their oxygen carrying capacity. It is associated with inability to meet the body's physiologic needs. It is quantified by a hemoglobin concentration of less than 13 grams per deciliter for men and less than 12 grams per deciliter for non-pregnant women. Prevalence of anemia before operation has been found to be as high as 60%. Pre-operative strategies. As I mentioned earlier, pre-op assessment history, physical examination, review of investigation results, and then history of inherited or acquired bleeding disorder should be documented. Patients should be asked if they are taking non-steroidal anti-inflammatory drugs or other anticoagulants. And then the type of surgery should be considered as it relates to the risks of bleeding. Major, huge tumors associated with huge blood loss. Physical examination must look out for anemia and bleeding tendencies. Severe hypertension may cause severe bleeding. Therefore, all patients that are hypertensive, they need to be controlled. Fluid blood count should be performed 4 to 6 weeks before surgery, and anemic patients should receive preoperative hematinics. Intraoperatively, there should be appropriate management of blood loss, and this could be influenced by the surgical technique, anesthetic blood loss reduction strategies such as regional anesthesia instead of general anesthesia where possible, and then pharmacological management. Laparoscopic surgeries are associated with a reduction in blood loss compared to open surgeries and laparotomies. There should be meticulous hemostasis to prevent perioperative bleeding. Regional anesthesia is an anesthetic blood sparing technique. There should be maintenance of balanced physiology such that hypothermia should be avoided, and then, of course, acidosis aids coagulation. Hypotensive anesthesia reduces blood loss, and appropriate patient positioning assists in reducing blood loss by improving venous drainage. Intraoperative cell salvage. If blood loss greater than 500 ml is anticipated, the use of intraoperative cell salvage is encouraged. This is performed with the use of a double lumen suction device to collect blood. Blood is stored within a reservoir with added anticoagulants. Once blood is collected, the red blood cells are washed, filtered, suspended in saline, and returned to the patient. So this is a diagram showing surgery going on. The patient blood is collected through the cell salver. The blood is washed, filtered, and then retransfused to the patient. Intraoperative cell salvage in obstetric should be considered in patients at high risk of hemorrhage, and it helps to avoid allogenic blood transfusion. Modern cell savers, they remove most particulate contaminants, and liquid reduction filtering of the salvage blood before transfusion add further safety to this particular technique. Antifibrinolytics, example, tranexamic acid and epsilon aminocaproic acid. They inhibit fibrinolysis by their action at the active site on plasminogen. They prevent the conversion of plasminogen to fibrin. Tranexamic acid should be used prophylactically in major surgery, such as orthopedic surgery. and then major cancer surgery, where perioperative blood loss is predicted to be high. Tranexamic acid has been shown to significantly reduce perioperative blood loss. This is a diagram showing plasminogen. The way tranexamic acid works, it prevents the conversion of plasminogen to plasmid. That way, fibrin cannot be broken down to fibrin degradation products. Tranexamic acid is recommended as soon as after onset of postpartum hemorrhage and within 3 hours of birth for all causes of postpartum hemorrhage. It should be administered within the first hour after injury too. Again, 1 gram in 10 minutes, that's 100 milligram per minute over 10 minutes should be administered. And second dose if bleeding is ongoing at 30 minutes. Postoperative strategy. The frequency of blood collection for investigation should be reduced. Reduce the use of postoperative drain, and cell salvage can be used to retransfuse blood collected from drains. In conclusion, blood conservation strategies and patient blood management improve perioperative patient safety and outcomes. Though blood transfusion is life-saving, its administration to patient increases morbidity and mortality. All perioperative health professionals should collaborate among themselves to practice blood conservation strategies for the well-being of the patient. Thank you very much. These are my references, comments, and questions. Thank you.